Hello, my name is SIADHJ Haarmann, and I am a McKendree University nursing student in the Master's Science in Nursing Education. Today I am going to talk to you about syndrome of inappropriate antidiuretic hormone. By the end of this presentation, you should be able to state 3 causes of SIADH, list the 3 criteria that must be met for a diagnosis of SIADH to occur, and state at least 2 treatments that are available for SIADH. SIADH is caused from an excess of antidiuretic hormone from either the pituitary itself or from another source, such as a tumor that is excreting antidiuretic hormone. This results in water retention without edema. You will also see a sodium of less than 135, and some patients will present with symptoms of hyponatremia. Those symptoms include nausea and vomiting and mental status changes. You'll see low urine output, but the patient will not be hypovolemic. Urine osmolality will be greater than 800, and this is due to the antidiuretic hormone stimulating the kidneys to reabsorb the water, which results in increased urine concentration. There are several causes of SIADH. It can be idiopathic, where there's no known cause. It can be iatrogenic. Medications can cause it, such as Lexapro. Serotonin can have an effect on ADH and increase the release of ADH. And the thiazide diuretics can cause the kidney to excrete more water, therefore leading to ADH, to the release of more ADH. Tumors, such as malignancies that can be found in the head and neck, can produce antidiuretic hormone, leading to SIADH. Neurological diseases, such as encephalitis or brain trauma, can lead to damage to the hypothalamus or the pituitary gland. And then pulmonary diseases, such as tuberculosis and asthma. This causes inflammation, which can lead to a neoplastic-like syndrome, causing the release of ADH. So certain criteria has to be met to make the diagnosis of SIADH. So it can be difficult to diagnose. You have to have low serum hyponatremia and hypoosmolality and urine hyperosmolality. So your sodium has to be less than 135 and your urine hyperosmolality, so it has to be greater than 800, and your blood osmolality has to be less than 280. There can be no evidence of any other conditions of the kidneys, thyroid, cardiac, renal, and your adrenal function and your thyroid function all must be normal, so no adrenal insufficiency or hypothyroidism. So if patients are in anything like acute renal failure, congestive heart failure, those things will probably overrule an SIADH diagnosis. So treatment for SIADH, patients who present with hyponatremia with severe symptoms will receive 3% hypertonic saline. Severe symptoms include confusion, vomiting, seizures, decreased level of consciousness. With the 3% hypertonic saline, they'll receive 100 to 150 bolus of 3% over 20 minutes. Sodiums will be checked every 4 to 6 hours. You do have to monitor the patients for osmotic demyelination syndrome. ODS is a nerve disorder where the myelin sheath of the nerves is damaged. And when this occurs, patients will have increased confusion, word slurring, weakness. And this is more likely to occur in patients who have sodiums less than 105, low potassium, alcoholism, malnutrition, liver disease, and happen when you overcorrect the sodium too quickly. So correction rate that you want to see is less than 8 to 10 millimoles every 24 hours. So that's why it's important when you correct potassium or sodium that you're checking it every 4 to 6 hours. Patients who present with hyponatremia with mild to no symptoms can often be discharged and followed up by their primary physicians, or receive some balanced crystalloid fluids and placed on fluid restriction of 1,000 cc's a day. And they will also be monitored their sodiums every 4 to 6 hours. In the second line treatment, that one can include drugs urea or tolvaptan. Urea helps increase water excretion. The one downside to urea is a bad taste, so patients may not always be compliant. And then tolvaptan is a vasopressin V2 receptor agonist, so it inhibits vasopressin, thus ceasing the water diuresis. The bad part with tolvaptan that patients may not be compliant with it is it's very expensive. So the reason for non-compliance may just be that they can't afford it. So not so much a non-compliance issue as an inability to afford the medication. So in review, SIADH is caused by an excess of antidiuretic hormone, either from the pituitary or from another source, such as a malignancy. There are many causes of SIADH, including tumors, medications, such as your SSRIs or your thiazide diuretics. It can also be caused by brain trauma or things such as encephalitis. And then diagnosis you have criteria that you have to meet for diagnosis, and make sure that patients don't have other disease processes that can be causing fluid retention. And then treatment consists of correcting the hyponatremia. And again, we must be careful as we correct that and follow the guidelines of slow correction and monitoring for that demyelination syndrome. Are there any questions? And here are my resources if you would like to have further reading on SIADH. Thank you for your time.